Good morning, and thank you for joining today's discussion, Centralized Virtual Care Design for COVID-19 Response, a forum for collaboration. All attendees are in listen-only mode. We will be answering questions at the end of today's discussion via the Submit a Question feature located on your GoToWebinar control panel. And now, I'd like to turn it over to your hosts, Northwell Health and Dr. Saurabh Chandra. Dr. Chandra?
Hi, Carsten. Thank you. Thank you, everybody, for joining the webinar. Before I start, I wanted to introduce our team members here who are with me. I have Dr. Mangla Narasimha. She is our Regional Director of Critical Care, professor at our medical school, and also overseeing our acute lung injury ECMO program, and as well as she is driving the critical care strategy for our health system during the response for COVID-19. I also have here with me Dr. Craig Hertz, who is our Director for Evidence-Based Intensive Care Practice, as well as our Associate Director for Tele ICU. With me here are Kara Benecke. She is the Clinical Director of Operations for the Telehealth. Patrick McCarthy, our Associate Vice President of Telehealth and driving the ambulatory strategy for responding to COVID-19, as well as Iris Berman, who is our Vice President for Telehealth, has been instrumental in setting up our telehealth program since its inception in 2014. And although Dr. Dorfler, who is not here with me, I wanted to mention him because our overall strategy for telehealth in the program in our health system is as a result of his vision, so just wanted to mention him as well. Our agenda for today's webinar is that we are going to start with a brief. I'll ask Dr. Narasimha to give a brief overview of what's going on with COVID-19 around the world, in the country, what's happening at Northwell Health. Dr. Hertz will follow that with giving an overview of the resources that are projected to be available, projected to be needed, and what we need to be focusing on. After that, I will give a brief overview of our telehealth programs and our strategy in the acute care space, followed by Kara Benecke, who will be talking about how we are responding in the Tele ICU, especially the nurses who are actually playing a frontline role and a very key role in our response to COVID-19 in the acute care space. After that, Patrick McCarthy will be talking about our strategy in the ambulatory setting, how we are trying to reach patients at home, and how he is driving that strategy, followed by Iris Berman, who will give you some thoughts around the evolving regulatory landscape. So with that, I'm going to turn it to Dr. Narasimha.
Good morning, everyone. Thank you for joining. We'll keep this brief and to the point. A little bit about COVID-19, and I know you've seen and heard a lot about this incessantly in the news. Saurabh, I'm not able to advance my slides.
Next slide.
COVID-19 is a coronavirus, which is, as you know, a cause of a very common cold, and it's seen on our respiratory viral panels that are used forever. This is a new coronavirus that has not been seen before, and that's why such a response to it. It's very similar to previous outbreaks. Both SARS and MERS were both coronavirus-mediated diseases, and both had a pretty significant mortality. Both were pretty self-limited because the virus had such a high mortality that over time, everyone that it infected was so super sick that it eventually just died out over time. This new coronavirus has a lower mortality, somewhere we think around 2% or lower than that, but the number of people it's infecting is so great that the morbidity from it is so high. It was first identified we think in November or December in China, in the Wuhan region, and we don't know a lot about it. We know that it spreads from person to person. We know that it has droplet from person to person. It also has surface, so we have contact precautions and droplet precautions on these people, and it comes from close personal contact, such as touching, shaking hands, coughing. There's been some reports I've seen where if a person coughs, linger in the air for 30 minutes in that area. So it seems to be very, very contagious and easily spread from person to person. And again, we think the mortality is somewhere around 2%. Very hard to get that number accurate because the number of people who have it are not accurate, so it makes the mortality percentage not accurate. And that is because testing has been such an issue around the world. So getting the actual N total is very difficult to do. Next slide, please. So we think this is an estimate. The number of cases that are reported is way under the estimated number of cases, again, because testing is not as widespread as we'd like it to be. We know that the number of cases may be 5 or 10 times higher than what's actually being reported. We're pretty convinced that in the local New York area that COVID-19 is very prevalent and underreported because testing, again, has been so difficult. Next slide, please. It's been discovered in every country and every continent except for Antarctica at this point. So the slide is already outdated, and it's outdated every day. We know that there are major outbreaks in Europe right now, and we're expecting outbreaks in Asia and Southeast Asia as this takes off there as well. And of course, the United States is what we're facing now, are the big outbreaks. Next slide, please. So as of this morning, the number changes minute to minute, but the estimate right now of people tested who are positive, that's again tested and positive, are 3,649 states. It's just West Virginia that has not yet reported a positive that have tested positive, and at least 66 patients, and I think that's a gross underestimate because we're not testing all of the hospitalized patients either. So patients are dying, and we're not realizing that it is coronavirus that they're dying from. So I think this is an underestimate of 66 patients that have died. I think it's a much higher number than that. Next slide, please. So how bad will the outbreak get? That's the golden question, right? So we know that the virus is very contagious. They're comparing it to SARS. We know the fatality rate is around 1 to 2%, and we know that this is the key, is that it takes a long time to show symptoms, but you're shedding virus. So I can get infected today and not show symptoms for 5 or 6 days, and all of those 5 or 6 days that I'm walking around and doing my normal activity, I am shedding active virus and spreading that to other people, not having any symptoms and not knowing that I'm sick. So that incubation period of 5 to 7 days makes this so contagious because people are walking around spreading the illness. And then once you are actually symptomatic, you are symptomatic and shedding virus for 21 days. So even after you feel better, they still think that they're still able to detect virus for 21 days, so a very long time. How much infection? We have hot spots of infection that we can see. There's a person in New Rochelle, there's a person in Miami that have been the cause of major outbreaks. So we know that there are people that are sort of hot spot places that are getting infected, but you can pretty rest assured that this is everywhere. How effective will the response be? So there are expectations that over 200 million Americans will get this virus at some point in time. To make that not in the next 2 weeks is the key, so that we don't overwhelm our healthcare systems, our ventilator capacities, our critical care capacities, to try to slow down that number as much as possible. So the curve will be a little bit longer and take longer to go away, but it won't be this huge spike, so that we'll be able to respond to it and keep people safe as much as possible. A vaccine, I heard this morning again, is already in human trial, but is over a year away. Next slide, please. So a little bit about Northwell Health, a little bit about treatment too. I'm not sure if anyone else is getting into treatment. We don't have great treatment. We're doing a bunch of experimental trials with a bunch of modifiers that will decrease the immune response to this, to try to prevent all of the multi-system damage that happens from this. But we don't have great treatments. We're really just supporting people through it with ventilators and oxygen until they get better. And that's what we're doing. So there's a lot of people working on treatment, but we have nothing definitive as of today to treat people with, and it's all guesswork, unfortunately. So our health system is a 23 hospital system. We are located in 5 boroughs of New York, and Westchester, Suffolk, and Nassau County. So we have a huge encatchment area of about 3 million people. We have an acute lung injury center that has been established over 2 years ago, and it includes a Vino ECMO program and an ECMO to go program. So for 2 years, we've been a regional center of excellence for ECMO for respiratory failure, and we've been going to other hospitals, picking up patients who are in respiratory failure and bringing them back to us for treatment of their acute lung injury. This has been through the telehealth system that we've incorporated, that we've been able to do this successfully, and you'll hear a lot more about that in a few minutes. And we have a combination of tertiary hospitals and community hospitals, a nice network throughout the New York area, so we have a good representation of the New York area. Next slide, please. Just a nice logo and some pictures of some of our hospital sites. Next slide, please. So again, we have 23 hospitals. We have 700 ambulatory facilities that feed those hospitals and are associated with those hospitals. We have 5 million patient encounters. We have 68,000 employees, which is the second largest in New York State, 4,000 employed physicians, and 13,000 affiliated voluntary physicians. Our operating budget as of last year was about $12 billion, with 30% of the inpatient market share of New York. We have a large training program of medical students, residents, fellows, and 1,700 of those altogether. We have a medical school affiliated with us through the Hofstra system, and that is the medical school where our medical students come from. We have an institute called the Feinstein Institute, which is our basic science research center, and about 4,000 researchers are housed in that center. And we have about 2,500 clinical studies per year that we conduct. So we also have strategic partners in Florida, Cold Spring Harbor, which is a research center, Krause up in Syracuse, Australia, Sweden, Maimonides Medical Center in Brooklyn, which is our affiliate, Nassau University Medical Center, and an Orthopedics Institute, and a network in Connecticut that we're affiliated with as well. Next slide, please. So as of 12 noon yesterday, we have 39 confirmed positive cases across our 23 hospital health system. 2/3 of those cases are sick enough that they've made it to the intensive care units. Our intensive care units are filled to capacity and have double capacity in the last 3 days. 80% of those in the ICU are on ventilators, already in acute respiratory distress syndrome, and 1 patient with COVID is on VV ECMO for confirmed positive COVID with severe lung injury. We have the largest cohort of patients right now in the New York area. I'm part of Greater New York and several other hospital conglomerates across New York, and we definitely have the largest recognized population of COVID in the New York area right now. So we have a large, very quick experience in the last 10 days that we've been able to get a little bit ahead of the learning curve the hard way. And we have an established, very, very well respected telehealth network going into this crisis. So we've been able to leverage that very quickly and uniquely, and we'll talk more about that in a minute. So that's a little bit about our health system and about sort of where we are today with COVID-19. Next slide, please. Now I'm going to hand it over to Craig Hertz. He's my colleague. He's a critical care doctor, and he's director of evidence-based ICU practice and the associate director of the telehealth program. So, Craig, I'm going to hand this over to you now.
Thank you, I appreciate it. Next slide, if you wouldn't mind. And so I also appreciate, you can see that we're sharing very similar information and we're keeping each other honest. So as Mongo had said, as of this morning, there's just over 3,600 cases in the US. The presumptions are that there's 100 to 1,000-fold greater actual number. The current mortality is around 2%. It initially had been in older adults. I think anecdotally, we're seeing patients in their 20s, 30s, and 40s that are requiring critical care interventions. The number of patients that are also being screened for quote unquote rule outs is in the thousands, if not tens of thousands. And all this becomes very important in the fact that, first off, we're discovering 600 new cases a day, but also the current recommendations for PPE utilization and isolation can very easily overwhelm a facility if they even have just 2 cases of potential rule outs. Next slide. So what is the concern and what kind of impact could this have? So this is some data that's been published. You can find on Johns Hopkins, SCCM has also published some of this. These are models. The dark blue, if you can see it, is hospitalization. The light blue is ICU care. This is numbers of patients. So you can see we range model-wise from the 1968 influenza pandemic of having just about 1 million patients with 200,000 of them requiring critical care, up to something as severe as a model from Health and Human Services of a 2017 pandemic with 11.5 million patients and 3.5 million of them requiring ICU care. What is kind of consistent is this range of about 25 to 30% of patients that do develop any of these model diseases will require critical care and intensive care units. Next slide, please. So where does that leave us? In 2018, and actually just recently published, Halpern et al. Said there's just over 96,000 beds. The Hopkins Center for Health and Security suggested the same. However, what they said is that 96,000 may be a little bit skewed with only 45,000 available and 45,000 in backup. One thing to keep in mind is that there are 22,000, 23,000 of those beds are actually neonatal. So there is a little bit of discrepancy in the sense of how many adult beds we have. I'm not going into pediatric information at the time. The other thing is that while we know that not all these beds would be occupied at one single time, we hope not, the duration that patients are intubated, which is over 10 days, sometimes even over 14 days, and the fact that general critical illness causes about 80% capacity in all of our intensive care units, this could very easily overwhelm our system. Next slide. Oh, I just wanted to circle that. Okay. So next slide, sorry. So what about folks that can cover these beds? Physicians, PAs, and NPs. Right now, there's an estimate of about 47,000 privileged and full-time equivalent intensivists. We're not really sure how many of the rest of the interprofessional team, nurses, RTs, pharmacists, that's there's a pretty limited information on that. NPs and PAs last year, 2019 in critical care medicine, there's a suggestion there's about 34,000 that could cover critical care. So this puts the pool of prescribers at right around 81,000. One thing to think about is that's very nice on a normal day. When you talk about disaster planning, on a conservative model, you would figure that 20% of this population would not be at work. Either they are sick, they're caring for folks that are sick, they're fearful of getting sick, schools, daycares are closed, whatever that may look like, which in theory would leave right around 64,000 providers and prescribers. Next slide, please. And this is where the fear of the mismatch starts to begin. While there is no specific number of what a safe ratio is, most will say that around 12 to 1 for one prescriber, physician, PA, NP, would be about the maximal for safe quality care. We know that 12 to 1 not only is a risk for the patient, but it's also an increased moral burden for our teams. And we know that in disasters and crisis that this moral burden, or burnout, if you will, becomes increases exponentially. And then that leads to greater attrition from our teams. Doing some math, this would mean that at current state, we could cover about 970,000 critically ill patients. If there's 20% that cannot care for them, then it would be 777,000. Next slide. It grows even further when you start looking at the various prediction models. So if we were to model after the 1968 influenza pandemic, we would require about 240,000 beds. For critically ill, we'd only have enough to cover 29% of that. You can see the graphs, or at least I hope you can. In the worst case scenario, we would have 3 million critically ill patients, and we'd only have 3% of the beds that could be covered. The AHA did put out a preliminary model of what they thought COVID-19 could cause. Then right now we're looking at only having 5% of the available critical care beds. Next slide, please. So let's talk ventilators for a second. Again, pulling from some 2010 data that was published by Halpern et al. And then the Hopkins Institute. Right now, we have just under 200,000 ventilators in 2010. 52% of them sit in the national stockpile that can be called up for emergencies. Being a little optimistic, let's presume that folks have purchased more ventilators in the past decade, which puts us about just over 200,000 available ventilators, and half of those are available in our hospital system without having to go into the reserve. Next slide, please. So who needs ventilators? As Mangla had pointed out, right now, we are seeing about 80% of the folks that are in our intensive care units requiring intubation. So these numbers are probably low that I'm presenting to you, and I want to keep that in the back of your mind. If we are conservative and say that 25% of patients that develop this require intubation, you can see that in a moderate model, you would have 180 that would need a ventilator, and we would have 188,000 ventilators there, so we'd have a decent match. In every other model, there's a massive gap of the number of ventilators that would be required and the number of ventilators that we have. Next slide, please. So when we put it all together, right now, if we had an event similar to 1968, we could probably manage it if everyone showed up to work and every ventilator worked. We have more than enough team members, and we have just enough ventilators. In any other model, right now, we would be, with the AHA model, we would only have 51% of the beds that could be safely staffed and only 13% of the required ventilators. That's, again, if everyone shows up and if only 25% of the patients that arrive require intubation. Next slide. And so I just wanted to share, not scare, but to share with you that there is a risk that 20% of our team members could not come to work, and that 25% of our patients, more than 25% of the patients will require a ventilator. And at current state, that outstrips our resources. So in this, I think we're turning it over to Dr. Chandra.
Thank you, Craig. So we've all heard about the crisis at hand, the shortage in resources, manpower that is coming, if not there already. Everyone has heard about telehealth and the promise of telehealth in meeting this challenge. I'm going to switch gears now and talk about how telehealth can rise up to the expectation and contribute in a very meaningful way in this crisis. We, like any other health system that uses telehealth, is trying to leverage our existing capabilities to help not only patients, but also our own providers. So I'm going to give a brief introduction to our telehealth program, and then actually talk a little bit about some strategies that we are utilizing in our acute care space, and what I mean with that is in the hospitals using our critical care Tele ICU team as well as our telehospitalist team. So Northwell Health, we have, when I talk about telehealth, I divide it into acute care space and the ambulatory space. Dr. Patrick McCarthy is going to talk about a strategy in the ambulatory space. I'm going to focus on our acute care side. In our acute care side, we have some number of programs, 24/7 programs in the Tele ICU, Tele Stroke, Tele Skilled Nursing Facility, and a Tele Hospitalist site. And then also and as well as a Tele Emergency Site 24/7 program as well. In addition to that, what you so sorry about that. I talking without asking for the slide, but yeah. So anyway, on our acute care side, we have different programs: Tele ICU, Tele Stroke, Tele Skilled Nursing Facility, and Tele Hospitals and Tele Emergency Site. In addition to the 24/7 programs, we have several programs that we have leveraged specialty services like neurocritical care consultations, trauma consultations, acute lung injury consultations, as well as pediatric critical care consultations, where we have given workstations in the units, and we can leverage those specialty services as the demand may be. So in our telehealth center, we started in 2014. We have round-the-clock critical care physicians, 4 to 5 experienced critical care nurses, 24/7 hospitalists. We have, during nighttime when we get busy, we have advanced care practitioners, nurse practitioners and PAs working alongside our intensivists. And then we have a 24/7 hub that is staffed by psychiatrists and behavioral telehealth care managers and other team members. Next slide, please. Next slide. And I'm skipping over, moving my slide. Okay, anyway, can you go back one slide for me? So this is our expected footprint for the year of 2020. You're seeing, very robust programs in Telepsych, Telestroke, Tele ICU. The Telehospitalist program is rapidly expanding, as well as the Telesniff program that we serve our own skilled nursing facilities and are also going out our health system this year. We have listed a telecritical care program, and what we mean by that is that we provide critical care services outside the ICUs. For example, in the EDs, providing consultations there. We provide oversight to rapid responses on the floors as well. Moving to the next slide, please. So I wanted to talk about how we are leveraging our existing capabilities and rapidly adding new ones to meet the demand that is there. So I'm breaking up into different domains. Let's talk about expanding access to critical care services. And how are we doing that? We have hardwired unit beds, 170 and more that we are seeing an influx of COVID-19 patients. But also our regional leadership, is taking steps together with the site leaderships in identifying designated floors outside our units, which are designated for COVID-19 patients, and COVID-19 patients are cohorted in those on those floors. So how can we provide and expand critical care services to those patients who are outside our critical care units and are being monitored by Hardwire? So we have as a priority, we are putting forward carts. We have a number of carts within our health system that we are deploying from prioritizing the need and redeploying where they are currently existing to meet those demands on the floors that are housing COVID-19 patients. We are also rapidly actually getting more carts as they're becoming available and utilizing. So that is one way that people can think about that. Okay, if you have an existing program, you have hardwired critical care beds, but you can expand your access to critical care services by utilizing carts outside those units. The triage and transfer. Since we are sitting in a telehealth center, we have a centralized model. we can rapidly assess patients in the ICUs and also on the floors using carts. And then we can look at different sites, and we have an idea about what resources are available on those sites and what is the acuity of the patient. And what we are doing here is we are rapidly assessing the acuity of the patients and the resources that are currently existing on those sites. And before the patient is deteriorating, we can make the call of transferring the patients to a higher tertiary center where there are more resources available. And I would like to mention, we have an acute lung injury center. It is in a tertiary hospital, and we have rapidly transferred patients from other sites as the need may be to this acute lung injury center. I wanted to mention about providing access to specialty services. So most of these patients, when they are in the ICU, they are there because of respiratory distress. Many of them are intubated. Many of them are requiring standard care of ARDS. Some of them may be requiring consultations for even other therapies like ECMO. So what we have done is we have provided access to the acute lung injury team. We have provided access to our cardiothoracic services. So we are thinking about how we can leverage our existing resources and tertiary, which are in a tertiary center, but we can leverage them through telemedicine so that they can consult on other community hospitals, because the end result is that the tertiary hospitals will not be able to accommodate all the patients in those tertiary hospitals. But using telemedicine, we can have our acute lung injury team, other specialty services provide consultations to community hospitals so that they can give advice on how to keep patients where they are already existing without having them to be transferred as well. So that's one of the things that we have been doing in our health system. Standardization of care. What we are seeing is that, and Mangla mentioned in her part of the talk, that there are a number of evolving discussions around what works, what doesn't work, in addition to supportive care and care surrounding ARDS patients, whether steroids works or not, whether chloroquine works or not. So there are a lot of emerging discussions, and Tele ICU, a centralized Tele ICU, plays a vital role here because they can provide help in standardizing care, in actually disseminating knowledge to every hospital at the same time, so that every single patient within the health system gets the same standardized care. And I think that's a very vital responsibility of our Tele ICU. And then we all forget about maintaining a critical care workforce. And we have, because a lot of these patients are coming to the units or in the EDs, and the decision or the identification for COVID-19 may or may not have occurred. And so it is actually putting at risk on our providers who are evaluating those patients, especially in the ED when not every data point is available to identify these patients. So what can we do to maintain our critical care workforce? So in addition to our centralized Tele ICU model that we already have in place, we are asking different hospitals to provide a list of their critical care providers whom we can provide rapid training and access to the software so they can see their own patients from their own building. So instead of going in and out of these patients' rooms, they can do a rounding, but if then they have to do, another evaluate the patient, then they can utilize access points that have been provided in these hospitals to see their own patients. Also, to minimize some of the risk, we are trying to evaluate patients in the EDs telemedicine rather than physically having the providers go into the ED, which is a high risk environment. So those are some of the strategies that we have been working on, deploying on our ICU side. In addition, I would like to mention that we have a very robust telehospice program that is staffed 24/7 by telehospice. The telehospice, as most of the patients will be admitted to the floor. A small percentage of them will be in the ICUs, and we are going to be utilizing our telehospice and leveraging the team to take care of the patients following the same guidelines that I just described for the Tele ICU side. So those are some of the strategies, and I would like to welcome questions and thoughts later on, and we can have a robust discussion surrounding that. So regarding the minimizing the exposure to the bedside team, I'm going to actually ask Kara Benecke, our Director for Clinical Operations, who has come up with a strategy, because if you think about the bedside, the nurses are at the highest risk because they are there for the patients all the time coming in and out of the room. And she has come up with a very good strategy. I'm going to turn it over to her to talk a little bit about how she's engaging our nurses in helping the bedside team.
Yeah. Thank you. So next slide, please. So I think we've quickly realized that the Tele ICU RNs have a unique responsibility to assist the bedside. So we created a quick roles and responsibilities with the last thing we want to do is confuse the bedside with any new workflows, and the goal was to keep it simple and to the point, and ultimately reducing exposure of the healthcare team and reducing cross-contamination. So next slide, please. Okay, great. Now I see it. Okay. So you can go back, actually. Great, thank you. So our changes in our workflow for the bedside RN, we're just asking that they call our team when they are entering the room. We've noticed that, especially with ancillary staff, they need more support with PPE education. So we're asking that the bedside RN notify us so that we're able to camera in and we're able to monitor exactly what they're doing. Also, we're able to help them bundle care, which we've had a lot of success with. We actually had a physician in one of the rooms who was going to contact the bedside ICU nurse to come in and actually change the settings on the IV pump. But with our nurses in the EICU, with their instruction, we were able to guide him through that, and that reduced exposure to one of the nurses. So the Tele ICU RN workflow has changed a little bit. We are initiating a phone call every hour and the conversation could be 30 seconds or longer. It's really just a touch base to say, hey, what's going on in the next hour, 2 hours? Can we help you bundle your care? Do you need us to support you in any way? So it's actually been working very well, and we're educating PPE in real time if needed. We've actually been able to identify 2 breaches in PPE, which resulted in sending 2 staff members home to be quarantined at 2 different hospitals. Currently, we have 12 COVID positive patients in our ICUs that we have eyes on, and we have 18 rule outs. Next slide.
Next slide, please.
Yep, there we go. So this is just, we created this to let the bedside, just as a reminder to let them know what we actually can do, because the anxiety levels, as you can imagine, are extremely high at the bedside. And even people that are trained in PPE and competencies, that they're forgetting what to do, and we're really there to assist them. So like I said before, we're monitoring PPE compliance. We're also maintaining the COVID-19 checklist that we maintain throughout Northwell for staff members that enter the room. So it's a full grid that we get the name of the patient, the name of the staff member, how long they've been in the room, the time they went in, the time they got out, what they actually did. So this takes the burden bedside because each unit is required to do that. That's something else that we've been able to offer them. And like I said before, we're doing hourly safety rounds as well. We were also able to identify, say your IV medication is running low. We had a hospital that only made 50 cc Diprovan bottles. We were able to reach out and call the pharmacy of that hospital and have them make a 100 cc bottle, just so we can limit the amount of healthcare workers going in the room to do tasks such as changing IV bags. We're also able to monitor lines, tubes, and drains. If we see somebody in the room, we're asking them to maybe turn the Foley towards the camera, set everything up so that we can see everything. They don't have to go back in for eyes and O's of a Foley, as long as we're able to see everything. We also have one ICU that doesn't have a phone in the room, so we actually served as their connection to the outside team. So if they were in the room and they needed something, they would just alert us, and we would actually contact the floor and get them what they needed. So, I mean, it's been an unbelievable engagement with all our teams. Right now, we have 5 hospitals that we're doing this protocol. It has changed our staffing, as you could imagine. Right now, we have 5. Next slide, please. So right now, we have 5 nurses on every day. One is a intake nurse / charge nurse, and we have 4 EICU nurses. We're currently looking to modify that staffing at this point. We also have 2 Apache nurses that we have daily. So we are actually going to convert them to 12-hour shifts and possibly reduce our data collection. And they are ICU nurses as well, and they could be the PPE surveillance monitors going forward. So, I mean, this is changing, every hour. We are bringing in extra staff and offering overtime. And we are discussing about not collecting our Apache data going forward, but it's an ongoing discussion so that we can focus on doing full surveillance for the bedside team. Also, another option was we contacted Human Resources to see if there were ICU nurses that were possibly on disability that could come and assist us. So that is ongoing. So we're just trying to really think outside the box of where we can get ICU nurses, because obviously we can't take bedside nurses away because they're all current. We have 2 nurses starting on orientation that we actually changed their orientation. They are ICU nurses, and we're really just training them up very quickly to monitor PPE, to learn camera etiquette for what they need to do. So those are just a couple of things that we're doing right now.
So I don't think we have a slide on the ambulatory side, but Patrick, I wanted to introduce Patrick McCarthy, our AVP for Telehealth Services. And he's actually has done a tremendous amount of work in setting up overnight, our capabilities on the ambulatory sites, because many practices are now switching from face-to-face evaluations to telemedicine. So, Patrick, if you can speak a little bit about how you are driving that strategy, that would be great. Thank you.
Sure. So on the ambulatory space, in the past, before the lead up to this particular event, we had about a couple hundred providers that were on our ambulatory platform. We use American Well here at Northwell for our ambulatory services. Over the last couple of weeks, we've shrank our development plan, which is normally an 8-week plan for a particular program, down to under a week. We've done that through a lot of automation. So we quickly created online training guides, hard copy content that we could distribute fast to the different sites. And we created an expedited path to get the projects in. As you can imagine, we're getting a lot of requests. So we had to create an intake and then a prioritization queue so that we can have senior leadership weigh in on the different providers that are coming on. But over the first 7 days or so, we've doubled our amount of ambulatory providers, and we are getting requests coming in by the 100, which is a pretty substantial amount of providers to get on pretty quickly. The goal really here is to expand our capabilities so that if a provider is quarantined, they can continue to provide services. The patients themselves, we're continually trying to push them to stay in their homes so that they don't actually get exposed to other patients. And then take care of those patients who are exposed or quarantined. Telemedicine seems to be the way that we're going to be delivering a lot of that care moving forward. I guess since it's already 11:17, I'm going to stop here and pass it on just so that we can get to some questions, because I know you guys are going to have some questions, and then we can move from there.
Thanks, Patrick. I'm going to ask Iris Berman to speak, our VP of Telehealth, to speak about evolving changes in the regulatory world.
Hi, everybody. Next slide, please. I'm going to make this really short and sweet. I know many of you have heard that the president did announce and use the words telehealth, and ever since that happened, my phone's been ringing off the hook. My emails are flooded just like the rest of my team, and making decisions around who gets what is challenging. But I will tell you that despite regulatory things, the Northwell philosophy is we're going to do the right thing and move this ahead. Some of it you may have to do retroactively to figure out how you're going to get reimbursement. There's a couple of parallel issues going on, but when we look at what that declaration of the state of emergency is, which is the Telehealth Services During Certain Emergency Periods Act, it has, believe it already, an acronym. What does it really mean for us? So it's the lifting of certain established limitations if the HHS signs waiver. I've been hearing and waiting to see, and unless something happened in the last half hour, that hasn't been signed yet. But the legal interpretation of this is that it will allow for patients in the CMS population, Medicare particularly, it allows for care in their home. So it's taken off that origin site restriction, and it also lifts those geographic restrictions that we've been dealing with to date. The person providing that care has to be a qualified health provider, somebody who is already qualified provider to provide Medicare guided care, and preferably within the 3-year period prior to the actual service that you're billing for now. They are now allowing a smartphone for the patient to be considered a telehealth device. So that's a change. It was very restricted before and can also be used for the provider as long as it's two-way audio visual. We have, again, not seen the sign-off on the waiver from HHS. That is supposed to be pending momentarily. And we don't know, once that waiver is signed, exactly the date that it will be in effect until. So that's the federal side of things.
Thank you, Iris.
And then, in addition, different states have had different proclamations of states of emergency. Sorry? States have individually declared their own instances. So in New York State, we have a telemedicine to facilitate treatment of patient in place, which we are taking to mean broadly use of telemedicine. And that's my quick and down and dirty on that. I would like to be able to turn it over so that Carson can open it up for Q&A.
Dr. Chandra, Iris, and the entire team from Northwell, we are grateful for your time and effort, not only working through the entire weekend helping patients, but obviously also preparing for this very important webinar. We have a few questions, and one area that I'm going to ask our facilitator to circle back to is slide 27. There are several questions about slide 27, and I'm going to ask that we move back to that slide to have further discussions. Can we transfer back? And then Dr. Chandra, if we can have a little bit of a deeper dive into that slide.
Or that was Kara.
So this focuses on the role of collaborative teamwork between the point of care bedside practitioner and the Tele ICU RN. Can you elaborate here a little bit more? And then also potentially answer the question about how these models are supporting staff sleeping schedules, or if you've modified your scheduling at all.
Tara has stepped out of the room. My name is Rose. I'm the nurse practitioner here. As far as sleeping schedules, we haven't run into any issues with having any sleep. We're not at that level of staffing yet. I have the unique ability to be at the bedside yesterday, and then I'm normally here at the core, so I was actually able to see this go into action. This is the guideline that we've put out. It's kind of a little bit site specific and nurse specific, but there is they're reaching out at the beginning of shift and saying, this is how we're going to run it today. I'll call you every hour if I need to come in, depending upon the how sick the patient is. The one where I was not that ill at that point, so there wasn't as much contact. Where if you have a more critically ill patient, they are honestly doing the hour-to-hour contact. Sure.
It's Iris. I also wanted to add that one of the things the nurses in the core have been doing is keeping our most acute COVID patients up on the camera for prolonged periods of time to continue observation so that the nurses can feel comfortable getting their breaks in and stepping out of the room. And I think that's kind of what you were driving at. It allows them time to recharge, and we have the ability to call. We have, contact information, either it's a Spectra link or a phone or somebody's cell to get a hold of somebody if we need somebody to get in the room in a hurry. But when we know those nurses are going out on break, those patients are up on camera.
Okay, thank you. And Dr. Hertz indicated that we are seeing longer lengths of stay for these patients. Comes to mind, or a question here online, is regarding the sanitization or the cleaning of telehealth equipment. Are there any unique protocols or steps that are being done for hardwired rooms within your organization?
So our guidelines are that however you clean the equipment for isolation rooms, the same guidelines exist for cleaning telemedicine carts and equipment. It's no different.
Okay, thank you, Dr. Chandra. Another question, earlier today, Governor Cuomo and likely other state leaders have emphasized the potential need to seek temporary hospitals. How would you see such temporary hospitals working with a site like Northwell? And what would be the top challenges and opportunities?
So this is Iris. One of the things we've been talking about this, and we're already looking at temporary testing areas and intake for the less sick. But even as we move to whatever these temporary facilities is, to look at mobile deployment of audiovisual mobile devices in the form of carts and being able to set up Wi-Fi capability. We're certainly not going to be able to necessarily hardwire locations, so it is in discussion as fast as we can get devices to have them strategically distributed. So one of the really important things which Patrick and team have been working on is knowing our complete inventory of devices and having central control by one source to know where everything goes. And then the critical care team is determining who needs for example, the carts, like we talked about, deploying carts to extension units, right, where there's COVID patients needing additional surveillance, where we want to decrease exposure. You still have a challenge, though. You have to move that cart around, which means cleaning it between room use. However, it is still the next best thing to just not having enough boots on the ground to go room to room to room.
Thank you, Iris. Another question looks at the concept of using telehealth or designating telehealth as an essential services. How do you receive consent to use of telehealth in the acute environment? And can you speak to the designation for essential services?
So this is Iris again, and it's interesting because this is a conversation that's been ongoing with some of my colleagues. We right now are asked to maintain and stay open. We are part and co-located with our central emergency medicine response team. We are also supporting 911 calls with telemedicine on the ambulatory side. So there's a number of pieces that we are factoring into. We aren't exclusively Tele ICU, so we are considered right now, for the moment and in this emergency, essential. We don't have that designation formally, I will tell you that. if there's any other questions around that, I think that's still an open discussion. Right now, we would not be a location that would be shut down. We are expecting and being expected by the service line to continue to support. It's the only way we're going to be able to extend critical care in this emergency.
Thank you. Last question. As we look at responding to COVID-19, this is the opportunity for a partnership between people, processes, and technology. What would be the call to action from companies like Philips and health tech companies that could best support hospitals and providers at this time?
So,
well, go ahead, Sarah.
I mean, there are many ways that we can do this. And I think this is a collective responsibility. And, one of the ways that, we are, so many ways, and depends upon the needs. For example, I'm throwing it out, we would be requiring a lot of carts because in a very short time, we cannot have hardwired equipment installed in every room. So one of the things that companies who are providing equipment, they can ensure that there is an expedited pathway for delivering some equipment. And I'm happy to note that our vendor, we just came to know about this morning, that they have expedited, they are responding to the need, and our delivery of cards have been expedited. So one of the biggest things that, telemedicine companies who are providing equipment, they can actually see and help different sites and hospitals who are needing them to provide expedited, process, have an expedited process in place. Now, also, I can always say that make it, ways like lowering your licensing fees, having your own team available. It's a collective responsibility that many companies can step up and rise to the plate and help us all.
Yeah, I would add that one of the things that we're being taxed with now is support. I mean, we're doing really well with it, but at some point, as we increase the bandwidth of telehealth, support becomes increasingly more important and needs to be 24/7 regardless of location if we're going to ever be able to keep up with the demand for the technology. I'd also stress, and it's not a new subject, interoperability is still a big player in this. The sooner we can get that done simply, the better and easier it'll be for us to be able to provide anytime, anywhere care by any service line.
Northwell, thank you very much. At this time, we are going to conclude the webinar. Following the webinar, we will distribute a recording of today's session, and also we will make available contact information so that we can continuously engage the forum collected here today. This concludes the webinar, and look forward to speaking to you again.